speaker series. I'm going to have Teresa Glenn introduce herself and then introduce Dr. Kirk-Sanchez.
Great. Thank you, Laura. So good noon, everybody. It's so nice to be here. Thank you for attending our presentation today. It is my pleasure and privilege to be introducing my beloved boss, Dr. Neva Kirk-Sanchez. She is a professor and she is chair of the Department of Physical Therapy here at the University of Miami Miller School of Medicine. Her clinical and research expertise is in the area of physical activity and exercise for the management of chronic diseases, and she has worked extensively with older adults in the areas of falls prevention and management, with an emphasis on people with neurocognitive disorders. She is a co-author of a falls clinical summary, clinical guidance statement for the management of falls in community-dwelling older adults, and a new physical therapy falls management clinical practice guideline, all sponsored by the Academy of Geriatric Physical Therapy and the American Physical Therapy Association. She's engaged in national and international presentations to both clinicians and the general public on physical activity and exercise for management of movement and health in older adults. So it is my pleasure right now to turn the camera over to Neva and listen to what she has to share with us today. Thank you so much, Neva.
Thank you. Thank you, Teresa. Appreciate the introduction. I'm so happy to be able to speak to everyone this morning about exercise and falls and fractures and osteoporosis and all those three things that go together. Thank you very much for inviting me to be part of this series. What I hope to do today is talk through the guidance statements, the guidance documents that have been developed by my colleagues and me and my colleagues and some of my colleagues without me, that really together create a package that really can begin to address falls and osteoporosis, which are so highly related to fracture. So we'll be discussing those recommendations. I'm not going to talk very much about methodology for that. I'm really going to try to get into some specific information about exercise and a little bit of discussion about Tai Chi as a modality. And then I hope I'm going to do this in sort of a case format. So I'm going to introduce a couple of simulated people who might be at risk for falls. And at the end, I hope we can have a little bit of discussion about barriers for implementing exercise programs, both from the perspective of people who might be at risk for falls and from clinicians who might work with those people. So I'm going to just jump right in, maybe if my slides will advance. As Teresa said, this work that we're going to talk about here has been supported and funded by the Academy of Geriatric Physical Therapy and the American Physical Therapy Association over many years through many grant sources. So this work really is a product of that support. So what I want to talk today is strategies that can address the high prevalence of osteoporosis, falls, and hip fracture. How to incorporate appropriate exercise into that management, and then to talk a little bit about the barriers, although I hope that can be more of a discussion at the end of this presentation. Okay. So this is a kind of a terrible triad when we think about the high prevalence of osteoporosis, the high prevalence of falls, and how both of those together lead to hip fracture as well as vertebral fracture and humerus fracture. But I think a lot of times we really, when we think about fractured hips and the impact it has on people, it's really something we want to try to do everything we can to avoid and prevent. So there are 36 million falls resulting in 32,000 deaths annually in older adults. This is a serious population health problem. It's the leading cause of injury-related death, falling in older adults. 90% of all hip fractures occur when people fall to the ground, so that they are standing or sitting and fall to the ground. 90% of fractures occur that way. So if we can begin to tackle falls and osteoporosis, we can also begin to tackle those hip fractures. Other kinds of fractures occur, as I mentioned before. And also in people with osteoporosis, fractures can occur without trauma, like falling to the floor. but a serious public health issue for everyone. Osteoporosis affects 10 million people in the United States. And it tends to progress. Each 10% decrease in bone density increases the risk of fracture by 2 to 3 times. So as people grow older and bones become weaker, the risk of fracture increases exponentially. Also very surprising is screening for women is low. Women 50 to 64 who certainly have high prevalence of osteoporosis are only screened about 20% of the time, and 65 to 79 about a fourth of the time. And over the age of 80, only 13% of the time. And certainly there's a increasing prevalence as people grow older. So screening is something that as a healthcare community, we can do quite a bit better with. And then hip fracture. So hip fracture is a leading cause of profound morbidity and loss of mobility, the ability to walk and care for themselves in people. It's also a huge financial burden to our healthcare system. $50,000 per patient, an annual estimate of almost $6 billion spent on falls and rehabilitation from falls and repair of falls. The 1-year mortality rate after a fall ranges from 14 to 60%. And women have a 5-fold increase, but men also fall and have osteoporosis and have almost an 8-fold increase in mortality after falling. So we know much less about men and osteoporosis, but certainly more information is needed about what exactly we can do about the risk for falling as men and as clinicians who treat men. So again, I wanted to frame this in the format of a case study. We can talk about Annie. She's 75 years old. She goes in for a cardiac catheter procedure. She doesn't realize the floor is wet. It's raining outside. She falls down. She reports immediately right hip and shoulder pain. She can't bear weight, but she's had no prior history of pain. She walks without a device. She walks without assistance. So the fall resulted in both a humeral fracture, so the upper part of the arm, and a femoral neck fracture. She had a surgical repair of the hip very soon after the fall, and she was placed in a sling and was discharged, maybe some complications after that fall, and was discharged a few weeks later. She's 5'3", 185. BMI of 32.8, so overweight, which is not always the case in people with osteoporosis. And I think we really do need to we think about people with osteoporosis tend to be more thin and frail, but this is someone who's not thin and frail with osteoporosis. Type 2 diabetes. She assumed she had osteopenia, but had never been screened. She's had 2 humeral fractures, upper arm fractures over the past 2 years. So this is a third fracture. After the first fall and fracture, she did physical therapy, but they just focused on her arms. They did some balance, but they didn't focus on leg strength or mobility at all. She didn't get PT after the second fall. She has a 20-year smoker, 20-year history. It's unclear the PAC years, and has a self-reported decrease in vision. So she doesn't exercise. She's not physically active. She spends most of the day sitting and hasn't ever been instructed in proper exercise. So what could Annie have done to prevent a fall, or what could someone have done to help Annie to prevent a fall? Well, there's opportunities there for education when she's with a clinician to educate on leg strengthening exercises, balance exercises. So even though she's not in for a hip fracture, it's possible to prevent a fall. She's reporting vision impairment. Vision screening is probably important so that she could see when there's a hazard in the area. And what can she do now to prevent another fall? So she's at much higher risk for fall and fracture now with her arm injured, likely in a cast, and pain in her hip after a fall. So there's lots that can be done to prevent a future fall, and lots that could have been done perhaps to prevent the fall that occurred. So the point is that osteoporosis and falls are both preventable health conditions and events, and strategic exercise really can go a long way towards prevention. knowing what exercises are best are key. So I'm going to jump into some of these clinical practice guidelines now. These are just two clips of the osteoporosis clinical practice guideline, which was published in 2022 by a group of colleagues, again, supported by the Academy of Geriatric Physical Therapy. And so there was a study, two different studies. One is recommendations for practice, and one is really looking at a wider scope of management of osteoporosis and prevention of osteoporosis. Again, I don't want to dive into the methodology, but there were many existing clinical practice guidelines reviewed. And what this team decided to do was take one of the already existing clinical practice guidelines and explore a little bit deeper the evidence behind it to see if they could actually come up with much more specific exercise recommendations. Many times when patients see a clinician, they're told you need to exercise to improve your bone health, you need to exercise to improve your balance, and the specificity of that exercise is lacking. So the objective here was to take one of these existing guidelines, look at the articles and the trials and the systematic reviews that supported them, and dig a little deeper for specifics on exercise. They looked at several high quality guidelines and chose the Scottish Intercollegiate Guidelines Network. This is a group of scholars in Scotland who actually do a lot of very high quality guidelines. So they took that the highest quality guideline, reviewed all of the articles that were involved in it to come up with some very specific information around exercise mode. So what type of exercise to do? What is the frequency and duration of that exercise? What are the any adverse events associated with that exercise? And then participant characteristics, because perhaps perhaps information is different for premenopausal versus postmenopausal women versus men. And they also looked at where the outcome they were looking at was a decline in bone loss. And they looked at two different sites. They looked at the hip, the intertrochanteric, related to intertrochanteric or hip fracture, and also at the lumbar spine. So these are what those guidelines are. So these are exercise interventions, specific guidelines related to decreasing bone loss in people with osteoporosis. Now, it's very difficult to, with exercise or with any modality really, to put bone back on. What we hope to see is that there's a decline in bone loss in people with exercise. And so let's take a minute to talk about these different types of exercise that might be used for decreasing bone loss. So the first is static weight-bearing exercise. So standing still, bearing weight on the limb, very simple single leg standing, and double leg standing for people whom single leg standing is difficult, but being upright and bearing weight through that limb. So when we think about static weight-bearing exercise, generally that's a single leg standing exercise. Dynamic weight-bearing exercise, low force, include things like walking and Tai Chi, where there's not a lot of impact with the ground. Dynamic weight-bearing exercise, high force, include things like jogging, jumping, running, and dancing vigorously. And then there's non-weight-bearing exercise, low force, and that's using weights around the legs and moving the limbs against gravity without the limb being planted. So that would be things like sitting in a chair with an exercise cuff on, or using an exercise machine where it's not done in standing. It might be done in sitting or lying down. So you can do that with a load or a low weight, or non-weight bearing exercise. High force is done with a much higher load or a heavier weight. And then a combination of exercises, any of those two types together. So we really can think about what type of exercise is most effective for for decreasing or slowing down bone loss at the hip and at the lumbar spine. These are two places that are highly likely to fracture. So and again, breaking this up by postmenopausal women and premenopausal women, we know that at the time of menopause, bone loss accelerates. And so there may be some different strategies for people who are in those two phases. So for postmenopausal women, to slow bone loss at the hip and femoral neck in the hip, the recommendation is static weight-bearing exercise, such as standing on one leg. And to do that for a long duration, not a long duration at a time, not to stand for an hour on one leg, but standing just 1 minute per leg 3 times per week and sustaining that for 24 weeks was shown to be effective in slowing bone loss at the femoral neck. Very, very simple exercise to do, very easy to describe to people, very easy for people to incorporate into their lifestyle. Other effective exercise, adequately dosed progressive resistive strength training exercise at high force. So using heavier loads, 1 to 3 sets, 7 to 14 repetitions, but a heavy load. So about 75 to 85% of what anyone could possibly lift. That feels very heavy for people, 2 to 3 times per week. And then impact exercise training, such as jogging, walking, or aerobics, did slow decline at the hip and femoral neck. However, that might be limited by some people who are of older age, the ability to jog or do aerobics, but certainly people may be able to easily incorporate walking into their lifestyle. So that was for the hip and femoral neck. And we see very similar information for slowing bone loss at the lumbar spine. Long duration exercise, using walking, Tai Chi, and strength training exercise, such as weight training, and then different combinations of those. So for bone loss at the lumbar spine, single leg standing or static balance isn't effective, but it is effective for bone loss at the hip and femoral neck. For premenopausal women, we see very similar activity there. High impact exercise and high force exercise is very helpful for premenopausal women. And then progressive resistive strength training. So using exercise equipment or using equipment in the home with the feet not planted but free in the air is important for slowing bone loss at the femoral neck. And we see the same thing for slowing bone loss at the lumbar spine. And we'll talk about what some of those exercises might look like in a little while. For men, there really is not enough evidence. Research hasn't been done to identify what kind of exercise is most effective for improving bone mineral density in men. What we do know is exercise for most people is safe and effective. We have physical activity guidelines that, were they followed, would be likely to decrease the bone loss in men as well. So, but there isn't enough evidence because they're at so much higher risk of mortality after a hip fracture. It is a very important group of people to focus on, and a very important group to continue to encourage to do higher level weight-bearing exercise. So this is just kind of a summary of what I just said. Single limb weight bearing is important for postmenopausal women for hip bone loss. Really not very easy to accomplish as well. Not really going to help with the other areas or in premenopausal women. But what we do see is non-weight bearing high force exercise helps at all levels, and combination exercise. So combining dynamic weight bearing exercise such as Tai Chi, walking, and jogging with high force non-weight bearing exercise can be very, very important. And again, we'll talk. I hope we can talk together as a group about how people can access this type of exercise. Other really important point: exercise has to be long duration, going from many months to many years in order to be effective. So exercise is a lifestyle change that has to be properly. People need to be properly educated on it, but then supported to make a permanent lifestyle change. It's not enough to do a 3-week exercise program or a 3-month bout of physical therapy. It really needs to be maintained. Just some examples for postmenopausal women: dynamic weight bearing low force, things such as walking and Tai Chi. The doses were an hour at 60 to 70% of the max heart rate. So people should be a little bit short of breath. Their heart should be racing a little bit, 3 times a week for up to a year before changes, meaningful changes can occur. And non-weight bearing high force exercises, again, 1 to 3 sets, approximately 70 to 85%. So heavy weights, 2 to 3 times a week for 3 months to 2 years. It really has to be sustained for a long time. So really critically important to work with people, or for people to realize and think about how they can put these kinds of changes into their lifestyles. So for Annie that we met earlier, she had undiagnosed osteoporosis. Had it been diagnosed, perhaps she could have been more proactive in doing the things that she needed to do. She never was referred to physical therapy for exercise or for education before her fall, and didn't receive adequate information about exercise and weight-bearing exercises specifically after her fall. So there's a lot of opportunity there to improve outcomes for someone like Annie. Okay, so I think we've talked a bit about that. I've covered my screen now. Wait a minute. Okay. All right, so let's move on to falls. In 2015, we published a guidance statement that actually we started the process by really thinking about what was already known about preventing falls, and how we could improve information for clinicians who are dealing with older patients. You'll have to excuse me again. I keep covering up the button that I need to move my slides. Okay. So this is really a review of existing clinical practice guidelines. Again, we reviewed a lot of guidelines. We looked at the highest quality guidelines based on a very rigorous methodology, and came up with a rubric for screening for falls and assessing for falls, and then some very general information about what type of exercise is best and what type of exercise and other kinds of interventions. And so our guidelines for screening are actually very clear. All older adults should be asked if they've, every time they see any practitioner, if they've fallen in the previous 12 months. And if they have some information about the history and context of that fall would be very important. And at least one question about the patient's idea about whether they feel that they have problems walking or problems with their balance. For everyone who reports more than one fall or reports one fall with balance problems, they are considered screening positive and at high risk for falls. So that should trigger a much more comprehensive assessment. So that assessment should include a medical history with emphasis on osteoporosis, depression, cardiac disease, and any kind of neurological disease that might impact balance, a medication screen. So their polypharmacy and the use of psychoactive drugs is related to falls. Our clients should be informed of that and to be careful about taking psychoactive drugs. And also people should be aware about polypharmacy in older adults. And then a very thorough examination of other types of body functions and structure, assessment of environmental factors and any other factors. So looking at strength, balance, gait abnormalities, how much assistance they need with activities of daily living. Footwear is extremely important, that people know what type of footwear to use. And then vision and urinary incontinence is related in that people with incontinence often will be getting up quickly at times and can be at risk of falling. And then through that process of looking at existing clinical practice guidelines, what we were able to pull from that is that strength training is important, balance training is important, they should be individually prescribed and monitored, gait training is important, and then correcting environmental hazards and footwear is important. But there was very little information about specifically what kind of exercise was most needed, what type of exercise, what format of exercise, how long it needs to be. And so really important. Oh, my light just went out. Hang on. That was a surprise. Okay. I need to move around a little more in here. All right, so that triggered our work to really look and see if we could find some specific information about what exercise is important. And this is the most recent work that was done. This is a clinical practice guideline. We've been working on it for many years, working with a team from University of Pittsburgh, Indianapolis University, University of Michigan, and Midwestern University. This document is complete, recommendations are made, and it is out for public comment right now with our with some experts in the field in our professional academy. So I'm not going to go into the methodology. We pulled information from about 80 systematic reviews. So this was a very, very comprehensive review of existing information about what types of exercise are most important for reducing falls. We were also able to stratify people so that people at higher risk of falls maybe have a little bit different recommendations than people who are at lower risk of falls. So someone who's at higher risk of falls will have had multiple falls. They may have the presence of frailty. They have had, again, multiple falls and a very apparent weight imbalance problem. So those people have a little bit different recommendations. So for people at higher risk, the recommendation is that PT-based, physical therapy-based, or some other type of movement expert-based exercise interventions are important because their exercise needs to be carefully monitored and balanced with the safety of those exercises. The best type of exercise is multi-component exercise that includes balance and may include other exercise modes such as strength training. Tai Chi can be provided. However, the effectiveness of Tai Chi in people who are at very high risk is not as well established, and there may be some risk of falling with that. But balance training should be progressive, so becoming more difficult and sufficiently challenged. So those are for people who are at high risk, who've already had multiple falls. Now, for people who are at lower risk, who may not have had any falls or may just have some gait and balance impairment or maybe only had one fall, community-based multi-component exercise will be sufficient and might be more accessible. Again, it would include balance and functional training and could include strength training as well. Balance training should be progressive. Tai Chi is absolutely recommended for this population, but Tai Chi should be provided by a trained professional. It could be in a group format. It could be in even a virtual format, but is very, very effective for reducing fall risk for people at low risk of falls. And so what we're seeing is, although strength training isn't independently very much related to fall risk, it is very important for osteoporosis and slowing bone loss. So incorporating both balance training and resistance training into these into exercise programs is very, very important. And it's important that exercise be intense enough to make a difference. So should be progressed as people improve, and should be high force. So thinking about this, okay, what does that mean? What is balance exercises that are difficult enough to make a difference? What does that look like? I just want before that just say that education and environmental modifications are key as well. So while people are building exercise into their lifestyles, also there should be some efforts to provide education and environmental modifications for people who live in risky environments. Okay, so multi-component exercise dosage should it be at least 3 hours per week? Usually that would be an hour 3 times a week, total volume of 50 hours over 6 to 12 months, and must include a balance training component. For balance training dosage, very, very similar recommendations for 3 hours a week, total volume of about 50 hours. But the idea is to progressively reduce the base of support. I'll show you what that looks like in a minute. Moving the body within and beyond the base of support through reaching activities, doing some voluntary stepping activities so that they can learn how to adapt their walking to prevent falling. And then also reactive stepping, also learning how to respond when there's a push or a perturbation or something that they have to quickly avoid in the environment, and also reducing the use of arms. So practicing standing and then on one leg, for instance, and then removing the arm. For Tai Chi, the most effective dosage is 3 times a week for a total volume of 30-60 hours. So again, about 3 hours a week. So this is what we mean by reducing the base of support. So if someone is doing some exercises, whether it's a dynamic weight shifting exercise or just practicing standing, reducing the base of support means starting with the feet apart. When that becomes very easy, putting the feet together and then moving into semi-tandem. So not quite walking on a tightrope, but maybe walking on a pretty wide balance beam and then to a full tandem position. And so doing this is a way of progressing balance. And it's something that actually individuals can do themselves using upper extremity support. They can advance exercises on their own, particularly people who are at lower risk. So things like using a chair and then learning how to balance on one leg without using a chair and moving the arms side to side so the base of support shifts around on the ground are other ways to progress balance exercises. And again, these are things that can be easily incorporated into the home setting, and that people really just need some information about how to incorporate and advance these kinds of exercises. Stepping exercises, voluntary stepping exercises, are things like obstacle courses or even dancing and or choreographed stepping or following stepping, things like We Fit that people can do at lower intensities where they're actually choosing to step or doing voluntary stepping, are very, very effective for reducing falls. So this is another option. And if people are either following someone on a video screen or following someone at the front of the room or trying to remember combinations of steps, the added benefit of having that be a dual task where they're doing a physical and a thinking activity together is really, really important. And then one of the most effective ways of reducing fall risk is perturbation training. And this is showing what that looks like using some equipment where the floor actually shifts back and forth. This wouldn't likely be accessible to people in their home environments, but you can get a similar type of thing by having people throw and catch a ball. And so they could do that with their support people in the home, or they could do that in a clinical setting. And this has really been shown to have a powerful effect, reducing rates of falls by 50% in some studies. So lots and lots of options and good ways to be creative with balance training to make it fun and accessible for people. Tai Chi is just really a resource that's wonderful for reducing falls. Tai Chi, if you compile and look at lots of different studies of Tai Chi, it reduces number of falls and the risk for falling. So reduces the number of people who fall and also reduces the number of falls by 20 to 40%. And the best dosage was between 30 and 60 hours in total, and more than 3 times per week. So let's just look at another case, and then we'll talk about, why this is so hard for some people to accomplish. So Emily is an 85-year-old female with a history of multiple falls. She fell most recently 2 weeks ago, as she was walking to open the door to let her dog outside in the morning. She was seen in urgent care. She suffered a contusion, a bruise on her right lower leg, and a left wrist fracture. She was treated with immobilization of the fracture. Previously, her last 2 falls, she fell while climbing steps to carry groceries inside her house, and also she fell while carrying a pot of water to the sink. So she had things in her hands when she fell and wasn't able to catch herself. And perhaps she fell while she's walking to open the door because she lost her balance and wasn't strong enough to catch herself. She lives alone. She said her physician suggested she use a cane to ambulate, but she doesn't use it. And that's very common. We see that commonly in the people that we encounter. She's a retired college professor, volunteers at a local botanical garden. So she has a lot of things in her favor. She's active. She's motivated. She's somebody who really has a good social network. We look at her medical history. She has osteoporosis, depression, anxiety, high blood pressure, but no cardiac history, no incontinence, no cognitive impairment. She takes a leave when she's needed for the pain. She takes Xanax when needed. That's a psychoactive drug, usually once or twice per week. She takes Fosamax to help build bone, a baby aspirin, vitamin D, and a multivitamin. Her vitals are normal. She has some pain in her left wrist and her leg, which would be expected after a fall. She wears loafers style shoes with little support, but has no visual or cognitive impairment or incontinence. So this is a very typical person. Might be somebody who's aging well in place, but is at risk for a catastrophic hip fracture or some other type of thing. There's lots of resources here that we can build on, but some things to pay attention to is that something like Xanax, which is increases the risk for falls in several studies. She needs to be aware of that when she's moving around. The loafer style shoes may increase her risk for a trip and fall, which she may not be able to recover from because she doesn't have the strength. So there's lots of things to consider for Emily. This is just a screening questionnaire. She has some positive screens here. She has a fear of falling. She doesn't use her assistive device like she needs to. The falls efficacy scale is also a fear scale, how confident people feel. Very, very mild depression. But her gait speed is slower, so she's walking more slowly. She's moving more slowly. She has some leg weakness, and she can't stand on one leg. So again, lots to work with here, lots of potential for improvement. So what would be helpful for Emily to make sure she doesn't fall again? So first, some environmental modification, moving things around. So maybe she doesn't have to carry things so much in her hands, being careful with a pet when she opens the door. But also a very good opportunity for education that's specific to modify her activities. And so based on the guidelines that are based on evidence that we have, the exercise program should be 3 times weekly for at least 45 minutes and at least 55 hours, which is 22 weeks, 6 months of exercise. High challenge balance training would be good for this individual. Resistance training would be good for Emily, and also Tai Chi. So those are things that are recommended and are likely to make a big difference in her falls. And in osteoporosis, when we look at resistance training, if it can be non-weight bearing high force training, it would be very, very helpful for her osteoporosis and to slow loss of bone as well. So what might that look like? So she could have, and probably should have, because she's had a recent fall, physical therapy in a clinic 1 or 2 times a week for 6 months. Resistance training for her trunk and extremities, using machines for strength training, and learning how to do that on her own in her home with equipment, or in a community center or gym with equipment. Doing some step training. So learning how to step and then progressing that to stepping with something in her hands would help with her problems. Perturbation training using moving platforms. Again, these are things that are available in the clinical setting, but not so much in a home setting. So difficult for people to do them on their own. But there are things like throwing and catching that might be helpful for her that also perturb. And then some other static and dynamic balance activities. And then also very helpful for her would be community-based Tai Chi for 45 minutes to an hour, a couple times a week. Now note that the recommendation is for exercise 3 times a week. But if exercise with a trained practitioner occurs 1 time a week and Tai Chi occurs 2 times a week, very easily that could add up to the 3 hours a week that are necessary for making a difference in falls risk management. So people don't have to do 3 hours of one thing. They don't have to fit into their schedule to go to the exercise, to the gym or to the physical therapy clinic 3 times per week. That can be quite a barrier. They can use different activities to get to the dosage that they need to be effective. So what are some of the barriers? The barriers for Emily, or the barriers for many aging adults? One is to sustain a 3 time per week program for 6 months. People who are busy, who are volunteering, who are active, or who have families or grandchildren or people that they're caring for may have a difficult time fitting 3 times a week exercise at a facility for 6 months, at least, because really these are lifestyle changes that need to happen. Also, some people are very nervous and fearful of high challenge balance programs, either stepping or perturbation programs. Also, availability of technology in physical therapy clinics. Even some of the most effective physical therapy modalities or exercise modalities may be related to expensive equipment that isn't accessible to everybody. And then the availability of high quality Tai Chi in the community. It would be useful for people who work with aging adults, or for people who might be at high fall risk, to have an idea of where these resources are available in the community, or to offer them themselves in the community. And then the cost to the patient for equipment or gym membership or physical therapy or anything that's there. So there are quite a few barriers for implementation. What we know is that we know what people need to do. What we don't know is how to best support them to do what they need to do. So, I'm going to stop talking now and welcome other people to talk. This is a prevention, a cycle that if we can kind of stop one of these cogs from turning in the wheel, we can prevent hip fracture, which are really, really very catastrophic events for most people. People who have multiple falls and multiple wrist fractures just decline in their ability to take care of themselves and their ability to move around their environments after every fracture. So avoiding those fractures is really critical to maintaining high quality of life. So, how can we change current practice? How can we change both the community-based care, community-based services that might be useful for fall prevention, and how can we change and make things much more accessible for people, and make sure that practitioners or clinicians who are working with people at risk for falls have the knowledge they need to properly prescribe exercise. So I'm very happy to answer any questions anyone might have, or engage in some conversation about resources and availability and specifics about exercise and balance training.
So there are a couple of questions in the chat. If you'd like for me to read them to you, I
Sure,
would be
that's good.
happy to do so. So Dr. Koffler says she loved the idea of ball catching to improve balance, converts it to a fun game. How is it done in the physical therapy clinic? Is it done on a single leg?
So it certainly could be, and ball catching on a single leg would have the benefit of really helping with bone density at the same time that it really helps with strength and balance, particularly strength of the trunk. So it could be in the benefit to that is in the physical therapy clinic, you have someone guarding the patient to make sure that they don't fall. If you were to ask somebody to do that kind of activity at home, you may be in fact asking or suggesting that they do something that would put them at high risk for falls. And that's something that you really always want to balance, the recommendations that you make for someone to do on their own at home with the risk for a fall or an adverse event, because it would be very easy to fall while catching a ball standing on one leg for anybody.
It's a very good point. Yes, and then somebody else has followed up with, so if somebody were to be playing catch, and how long would you suggest that they would do that per session?
Well, just like when you do weight training or workout in the gym, you kind of do a set or a certain number of repetitions in a set. You can use kind of the same kind of philosophy when you're doing balance training, that maybe you do ball catching for a minute or for 45 seconds, minutes. And so you could do it in short bouts. You wouldn't want to do it for a long time because it would be fatiguing for someone. Now, obviously, you could work up to a higher intensity, but when you talk about progressing exercise, that's exactly what we mean. Progressing the length of time, or progressing the amount of force, or if you're weight shifting, progressing the distance that you're shifting outside the base of support would be really important. Ball catching is particularly good because it's not an expected, it's a perturbation, even though you're not, it's a lot more fun than being pushed, is to have some ball to catch, which actually also pushes you in the same way, particularly if you use weighted balls. So weighted balls are an option, like medicine balls.
Thank you. So then also, do you in your training, do you suggest situational awareness, risk assess for people to become more aware of their environment, in addition to some of the other training that you do with your patients?
What I didn't talk about today very much was dual task training, which is an area that I do some research in. So dual task training really can bring in that idea of situational awareness, right? Being able to attend to what's happening in the environment, what's happening around them, at the same time that they're paying attention to their walking or their gait. And so that could mean having a conversation with someone while exercise is going on. It could mean having them scan the environment while exercise is going on. You know, there's some things to think about. You know, if you're turning your head, then you're pulling in your vestibular system. So that may or may not be a good idea. But absolutely having people engage with their environments in a cognitive way can also be something that improves balance. What we know is that a lot of balance events occur when people are doing two things at once, right? They're walking and they're talking, or they're that would be a cognitive task, but they're walking and they're carrying something. Those are two motor tasks that are going on. That, you know, people can practice that as well. They could do it in the home setting, or they can do it in a clinic-based setting where we can do some pretty sophisticated dual task activities with people with balance impairments.
So another question, does Medicare cover 22 weeks of 45 to 60 minutes of physical therapy that you described for Emily?
So it would depend on the code, you know, for what reason they're coming for physical therapy. That's why it becomes, you know, really important to think about sustainability, right? So perhaps it depends on what kind of plan people are on, but perhaps it's visit limited, where there's only 10 visits or only 20 visits. In that case, it doesn't make sense to see someone for 2 times a week. You may want to see someone in physical therapy 1 time a week and have them do something on their own the other 2 times. The important piece is to tell them exactly, you know, what are the recommended things to do on your own, a Tai Chi class or a home exercise program. But, you know, it's sort of, Emily demonstrated that we could have structured physical therapy that included education on home exercises 1 time a week, Tai Chi 1 time a week, and a home program exercise 1 time a week, which equals 3 hours a week. Which would be getting at a very high dose of exercise that can make a significant difference in both bone health and fall risk.
Great. So somebody asked about Tai Chi classes, and where do you know of a place where they can look up to where they can find Tai Chi classes in the area?
So I wish I did have that information right to tell you right now. Where I would start is to look at the senior centers that are supported by state dollars. So the congregate meal centers and the other types of senior centers. Many of them have a website that can show you exactly what the exercise schedules are. Lots and lots of senior centers are holding Tai Chi classes. So that's a place to start in a community center like that. And Silver Sneakers also is a great resource. A lot of the places that have Silver Sneakers classes, which you can also find online, online resource that tells you where Silver Sneakers are located, are also holding Tai Chi classes. So, you know, it's kind of getting on the internet and searching for that. And I don't treat patients clinically very often now, so I don't have those resources in my hand, but it would be easy to create a list of resources of Tai Chi classes in particular areas.
And we should probably come up with a list and help with that and send it around if somebody's interested. Just email me. Let me give you my email address. So I will try and do my best.
And I'm sure also that there are virtual resources for Tai Chi classes. Just you know, that would be a very, very good option to have a website or something on the TV that you could follow the Tai Chi class. That would be an excellent option. You don't get the socialization that way, which is also very, very important, but that would be a perfectly appropriate way to do Tai Chi classes.
Yeah, and somebody did mention Tai Chi and group exercise is a great way for older adults, not only for strengthening, but increasing social life and preventing depression. And so, yeah, the online is another option as well, and definitely, but the reason why I'm also taken to this question is I've done Tai Chi research, we need to talk, and found that and as well as a lot of other people have found that there are a lot of psychological benefits to doing Tai
Sure.
Chi as well as
Sure.
the physical. So,
And the same is true with any type of exercise. There's a huge
Mhm.
psychological benefit to to exercise. It's, you know, it's over and over again been shown to be as effective as medications for reducing mild depression.
Right.
I do want to, there also has been a debate in recent years about recommending walking programs for people who are at very high risk of falling, just because there's been some evidence with walking programs that it increases the risk of falling because they perhaps are walking in environments that aren't safe. So I do want to just lend a word of caution for that. If we're recommending walking programs, that we make sure that there's a safe place, a supported place to walk. And the same is true with resistance only training programs, as it very good for osteoporosis, so for reducing bone mineral density. But there's been a few clinical trials that have demonstrated that resistance training alone that doesn't incorporate balance training actually has led to an increased risk of falling. So that's something also to be cautious about. And for patients who are at high risk, but really patients who are at high risk may need some skilled physical therapy to engage in the levels of exercise that they should be doing.
Great point. So there's somebody asked about yoga and whether you know anything about whether there's benefits to yoga that are similar.
So in the literature, there has really not been research done related to yoga as an intervention for falls risk management. However, there is evidence that yoga is beneficial for other types of problems. So, you know, yoga has such a mind body benefit. So I know the literature on falls. I don't know the literature on things like depression, and you know, obviously flexibility and things like that. And there's a social component. So I am a very big supporter of yoga in safe environments. And there are yoga that's very appropriate for people who are more frail or at higher risk of falls. But as an intervention for falls risk, there just hasn't been research done on it.
Let's see. So for seniors, somebody asked how you can assess when it's time to increase weight or difficulty. Figured you would
Oh,
be good at answering that
So-
question.
so yes. So remember that when I talked today that the emphasis, the real benefit for bone, slowing bone loss comes with high force exercise. So when you think about high force exercise, that means you're lifting heavier weights. It should feel quite heavy. So lifting a lightweight 25 times is not going to have a benefit. So when somebody is using a weight that they can do 18, 20, 25 times, it's time to increase that weight. And so that when they do it 8 times or 6 times, it feels heavy and they can't do anymore. So it really has to do with how it feels to the person who's lifting the weight. When it feels too light and they could do it all day, it's time to increase that weight. So, you know, that's really the guideline that we use is, you know, how many times can they do it before they're fatigued? If it's, you know, more than 12 or 15 times, it's time to increase that weight.
Okay, so let's see. There's do you know anything about Qigong?
I do not know.
Yeah.
I mean, I know what it
Okay.
is, but
I figured, yeah, it's similar to Tai Chi. So
what I will tell you is that
It's
we have
okay.
a very comprehensive review of the interventions for falls. And you know, it's not in the literature as a to reduce falls, but that doesn't mean it's not a wonderful modality for
Yeah,
really.
I've just, yeah, since it's similar, I guess that's why somebody was asking. There's another comment on suggestions, if people are working and can't get to a senior center, and the gyms, they're not really, or I guess, I'm not sure what the question is, but, or do you have any other recommendations? I guess
So,
more like,
you know, I think there's some benefit. And if you, oh, my lights are going out again. Wait a minute.
oh no. You've had all kinds of technical difficulties, it sounds like.
A bad morning. I'm sitting
Mm.
too still. I think it's just because I'm not moving anymore.
Right, you gotta do this every day.
Um, I think I think there's an opportunity to speak to people who are running gyms or community centers or YMCAs to ask them, if they thought about offering Tai Chi classes. Because I think, some people don't quite know what it is and don't really know if they want to do that. But I think there's an opportunity to ask community, people who run community programs if they'll offer that. I also think that virtual Tai Chi classes are a very viable option for people who are busy. And, Tai Chi is not just beneficial for reducing falls, it's beneficial for young people, for old people, for lots and lots of things. I think that there's an opportunity to do that. And, I would like to see that we could, there's a lot of yoga in the park programs right now. I wonder if there's not an opportunity for just some community, getting some enthusiasm in communities to do Tai Chi in a park. If you can find a practitioner, and there are practitioners who might be very willing to do Tai Chi in the park and kind of help gain awareness of the benefits of Tai Chi for many, many health conditions and general wellness.
Yeah, that would be lovely to be able to go outside and see people doing that in a park.
Yeah, I'm encouraged by how much yoga in the park. I'm seeing yoga at the farmer's market, yoga in the park, and I could envision that Tai Chi could, be as it is in many other parts of the world, having Tai Chi classes out in public spaces would be wonderful.
That does sound wonderful. Maybe the Osher Center should start looking into doing something.
Great start.
Exactly. So somebody has asked, and we only have 2 minutes left before, do they have it right that strength training alone does not keep us from falling unless those include balance exercises?
So the evidence suggests that strength training alone doesn't improve balance. Now, having said that, doesn't decrease the risk of falls. So strength training alone doesn't decrease the risk of falls. Including a strength training in a multi-component exercise program does decrease the risk for falls. Having said that, strength training to build muscle, there are metabolic benefits. And so it's not that it's a bad thing. It's just not been shown by the evidence in randomized clinical trials to reduce the risk for falls. And in very frail people has increased the risk for falls when not properly monitored. So you just need to be aware of the risk for falling, while doing resistance training.
Great. Well, I don't see any more questions.
Thank you.
And it's right exactly at 12:59. So if there's one short question or otherwise, I would just love to thank you,
Thank
Dr.
you.
Kirk-Sanchez, for all of this really great information. I learned a lot, and I'm sure everybody else did as well.
Thank you very much.
And yeah, I will, if somebody wants to email me, I will look into Tai Chi classes that if I can find anything on the internet, and we will.
I actually have a contact, so we'll talk about the person that I know who does Tai Chi classes in the community.
Nice. Okay, that sounds great. So thank you so much. This is really great.
Thank you.
Thank you, Neva.
Weekend.
Thanks, Neva.
Thanks, Dr. Schwartz. Thanks,
Bye-bye.
Terry. Bye.